So welcome to this sponsored session from Abbott, dedicated to the Navitor THV platform, a new TAVI solution with an active sealing technology. So my name is Didier Cheche. I'm interventional cardiologist in Toulouse, and today I have the great privilege and pleasure to share this session with friends of mine. So there will be, as you can see, Michael Lee. Hi, Michael, from Hong Kong.
Hi.
There will be also Anthony Camuglia from Austria. Hi, Anthony. And Lars Søndergaard, that you all know, so from Copenhagen. Guys, we have a quite dense session. It's going to be very interesting. We're going to get a kind of overview of all the features from this new TAVI platform. But let me start with the learning objectives of today's session. So TAVI has got to maturity, and we even saw an expansion of the indications promoting the use of TAVI in low-risk patients. So we have to be more demanding in terms of preventing complications. So today we're going to see how this new platform may be helpful. And the first objective would be to discuss the novel sealing technology in this next generation transcatheter heart valve. The second objective, as we try always to streamline TAVI procedures, because we have seen in our experience and all around the globe that streamlining the procedures improves the outcomes for the patient. So the second objective would be to try to understand how to simplify the TAVI procedure. And once again, there is that promotion of the use of TAVI in younger patients, lower risk patients with longer life expectancy. We need to discuss what are the considerations for lifetime management of patients with aortic stenosis, focusing on the low risk patients. So this is a quite dense agenda. But meanwhile, keep in mind that you have the opportunity to ask any type of comment, questions. So feel free to do so. And Michael will be the moderator, so we will have time to answer anything that you have in mind at the end of the session. So feel free to pop up your questions interactively. So let's start the session, and the first recording, the first presentation will be about the technology itself. What is the Navitor system?
Anthony Camuglia here, cardiologist from the University of Queensland, Australia, and it's exciting to be at Tokyo Valves PCR 2021. And I have the delightful topic of talking about the next iteration of the Abbott TAVI system, the Navitor, with its Naviseal technology, and how this is a major step forward in the treatment of patients with aortic valve disease. The Navitor system represents a true iterative improvement on the previous Portico system. All the great things about Portico, its deliverability, its low profile, its intra-annular leaflet design, large cell size to maximize annular conformability and coronary re-access, are all still present. The low profile with 14 French and 15 French delivery system, depending on whether it's the 2325 or the 2729 valve respectively, are all maintained, as is the repositionable, retrievable nature of the system, but with important, carefully engineered improvements in the valve itself. The valve now has an adaptable fabric PVL mitigating cuff called the Naviseal. In addition to that, the radial strength of the system, especially in the smaller sizes, has been improved, and it has been optimized for a 3 millimeter implant depth to minimize conduction disturbance and permanent pacemaker requirement. The large cell geometry, which has the dual benefits of maximizing coronary re-access, as well as allowing interaction and communication between the valve frame and the annulus to allow for nestling of calcific nodules so that the valve can conform to the annulus to minimize paravalvular leak are still integral to the design. But the Naviseal outer cuff provides an important major step forward in reducing paravalvular leak. And this, combined with the increased radial force with greater predictability of valve opening and conformation to the annulus, represent a major improvement in the ability to treat aortic stenosis with a self-expanding system in all settings, including calcified annulus and outflow tract. Again, the previous non-flared optimal height inflow in the LVOT is maintained. The tips of the aortic component have been made less traumatic with an increased inward curvature, which reduces the risk of aortic injury. And as per the Portico system, a large range of annular sizes can be treated with this system. The system is intuitive and incorporates the next generation FlexNav delivery system as a routine part of all procedures. The flexibility, deliverability, and low profile of the system mean that the Navitor system is actually the lowest profile, most deliverable system of any TAVR available from the major vendors, and provides a significant advantage in the breadth and width of patients that can be treated safely with minimal risk of vascular and other complications. The leaflets are made of bovine pericardium, as was the case with the Portico system, with the specific anti-calcification treatment to minimize leaflet degeneration and maximize valve longevity. The intraannular design, compared with the self-expanding low-profile frame, maximize effective orifice area and minimize patient prosthesis mismatch, which is a frequent counterpart seen in patients who are treated with balloon expandable designs. With this, all the advantages of a self-expanding system are maintained, but unlike some other self-expanding systems, the leaflets are intraannular, and that, combined with the large cells and the conformability of the system, maximize coronary access, which is becoming increasingly important in patients who are low to intermediate risk and may require TAVR and TAVR in the future. The system can be used in transfemoral or transaxillary approaches safely and predictably. Even in patients with horizontal aorta and vertical annulus, the system is incredibly stable. The excellent stability in hemodynamics during deployment are maintained without the need for rapid pacing. The valve opens symmetrically and predictably, and integration of the cusp overlay technique, or the recently described frame focus technique by Ganesh Manoharan, are both ways to ensure a high implant height of 2 to 3 millimeters to minimize paravalvular leak and conduction disturbance. And finally, the engineering changes that have been integrated into this system mean that the Navitor really now becomes the leading transcatheter aortic valve replacement prosthesis and addresses all of the things that as operators we've seen evolve over time and are now integrated into guidelines around the world, where we're really focusing on providing patients with a treatment journey so that down the track, access to coronaries and TAVI is a prospect that we don't have to face with trepidation. The intraannular system means the advantage of coronary reaccess is maintained even with a TAVI and TAVI. But unlike other self-expanding systems that have supraannular leaflets, the intraannular leaflet design means that the risk of coronary obstruction combined with the large cell size is minimized to allow for recurrent procedures as we plan a lifetime journey for these patients. And at the same time, maximize the benefits from high effective orifice areas, which are not demonstrated in patients receiving balloon expandable systems. And with the Navitor system, we now have the best of both worlds, an intraannular leaflet design with coronary access maintained, including for TAVI and TAVI procedures, but without the cost of reduced effective orifice areas that we see with balloon expandable devices. So really, to conclude, the Navitor is extremely exciting. The 30-day data in 120 patients recently presented showed no mortality at 30 days, incredibly low stroke and major vascular complication rates, and minimal to no paravalvular leak in the vast majority of patients. This really is an exciting time to be a TAVI operator.
So thank you very much, Anthony. This was a quite comprehensive and extensive description of the features of the Navitor system with the Naviseal technology. So I'm really looking forward to see it performing to clinical practice. So Lars, please show us a case of the Navitor.
So welcome to Copenhagen. I'm here with my colleague Ole de Backer, and before we go to the case, Ole, maybe you can give a short presentation of the case we're going to treat today.
Yep. Sure. Okay, so let's go to the slides. So this is a TAVI case with the new Navitor valve from Abbott. So the case we selected for today is a 77-year-old female, normal body size, I would say. She is known in her medical history with arterial hypertension and atrial fibrillation, and now she presents with severe symptomatic aortic valve stenosis, dyspnea, NYHA Class 3, no angina. So on the transthoracic echo, she presents with a left ventricular ejection fraction of 30 to 35%, AVA of 0.8 square centimeter. So on the rest echo, we measure a peak and a mean transvalvular gradient of 54 millimeters mercury and 31 millimeters mercury as a mean. However, there is a good left ventricular contractile reserve, so she also underwent a dopamine stress echo, and there the gradients clearly went up to 71 and 44 millimeters mercury. So this is clearly an indication for treatment. So on the coronary angio, there's no significant stenosis. And on the ECG, there is, as said, the atrial fibrillation and a QRS of 166 milliseconds with a left bundle branch block pattern. Her labs, hemoglobin, rather, unspecial, so 11.2 grams per deciliter, well-preserved renal function, and in general, an STS score of 3.3%. So then if we dive into the CT analysis, so of course the most important to start with is the aortic valve or the aortic annulus. There we measure an annulus perimeter of 80.5 millimeter, or a perimeter derived mean diameter of 25.6 millimeter. You also see a discrete calcification of that annulus level. And then of course we also measure into the LVOT 2 to 3 millimeters below the annulus, and these are very similar measurements. So if we go to the next slide, we also measure of course the coronary height. Left main a tiny bit lower, 11.5 millimeter, but still safe for this, for sure, for this platform we're going to use. And then the right coronary artery at 16 millimeter. Then the sinus of Valsalva, of course, is also of interest to measure, so 29 by 32. And then you see here the moderate to severe leaflet calcification. There is good calcification on all three leaflets, matching with her severe aortic valve stenosis. Next. And then aortic root angulation is looks good, 45 degrees. ST junction, there is clearly calcification there, and ST junction diameter is 24 by 27 millimeter. And then if we look to the aortic arch here, I have to say that the aortic arch has a pretty sharp angulated. So this can be a challenge for crossing the arch. And then, of course, we are also very much interested in the cerebral vessels because we are going to use cerebral embolic protection. So you see the truncus brachiocephalic, we measure the diameter there, and we already have a look on the left carotid artery to see how much distance there is between the truncus brachiocephalic and the left carotid artery. So next. And then the access, this looks pretty good. There is some only mild calcification. There is good luminal diameters of above 7 millimeters. So the plan for this case is a TAVI case in local anesthesia only, ProStyle vascular closure device, Sentinel cerebral embolic protection device, as said, pre-dilatation matched to the minimum diameter of the annulus of a 21 millimeter balloon, and then the new Navitor valve with this active Naviseal cuff on the outside, and a 29 millimeter size.
And again, very atraumatic nose cone here. We have the capsule here with the valve inside. We have the integrated sheet. It's very hydrophilic, so it's easy to introduce. And then you have this stability layer here, which is going to mitigate how much is going to dive towards the LV during deployment. So we're going in here, yeah, and now the integrated sheet is all the way in, so I can reconnect to the hemodynamics. And again, since it's a quite acute angulation, let's go quite a lot of LAO to make sure that we can actually see how it's traveling around. So let's see, again, it's a challenging anatomy, but this is a flexible system. So so let's try here, and you can give me a little bit of railing. 1, 2, 3.
Yes, I'm doing
1, 2, 3. 1, 2, 3.
Yeah, and then
you see that it makes that small kink, which often facilitate to take this quite tortuous anatomy without any major risk of vascular complications. So going to here, and
you go to a cusp overlap. It's just called LARIO, something here.
Yeah.
Like that.
So again, we're working here in a cusp overlap view. This means that the right and the left coronary cusp is overlapping. As we see here, the advantage is that you're going to have often no parallax in your delivery system and still have the 3 aortic cusp line, which is of course going to give you a better understanding how deep you are with your implant. Furthermore, you're going to elongate the left ventricular alpha tract, so you have a more one-to-one understanding on your depth of your implant. What we could try, Ole, if you can see, we can try to see we can make a commissure alignment here. So we can try to rotate and looking at the posts at the top here, in the middle of the frame. We want to see if we can isolate. Just give me 1 second here. We can maybe increase. So let's try to rotate a little bit here on the delivery system and see if you can have one of the posts on the far right hand side of the screen and
quite a bit now. Yeah,
I think we have
kind of one is more or less isolated.
Yeah, so again, in the middle of the stent frame, it looks like one is isolated on the right-hand side of the screen and the 2 others overlapping on the left-hand side of the screen. This should hopefully going to give us commissure alignment afterwards, which is important both to be able to access the coronary arteries, but probably also for the durability of these valves. So before we start, just let's do a first injection, confirm that we have the pigtail in the bottom of the non-coronary cusp. I think we got that.
Yeah.
And I think you see we want to be in somewhere in between the bottom or the inflow part of the stent frame and this first intersection where we are now. So I think that's going to position the valve about 3 millimeters below the aortic annulus, which is the target here. So I'm just doing slowly counterclockwise rotation here on the handle. You see that radiopac ring at the end of the capsule is now moving up. It's at the inflow part of the stent frame. It's now halfway up to the first intersection. And here at the first intersection is the position where it starts to flare out. I think it's sitting very stable here, and we're not doing any pacing. It's an intra-annular position of the leaflet, so often you don't see any compromise on hemodynamics, which is of course also important in this case with a patient with severely impaired LV function, that you don't need to do rapid pacing or long time pacing here. So now we're up here at the stop button. I can just go a little bit more. And the important thing here is to roll back to now a classical LAO cranial projection and confirm that we actually have the implant below the left coronary cusp, which we got. So I think we're sitting here in a very nice position. I'll be very happy about this position.
Yep.
So what we can do now, Ole, is that you can take some tension off the guide wire.
I'll do that.
I'll go a little bit further up here. And as long as you have that radiopack ring at the end of the capsule below the metal part, you can actually still recapture if you want. So we're going to deploy here. I'm pulling the pigtail back, and we go slowly here at the last part here. And I see at least 2 of these tabs that are out. Maybe we also have the third one. I think we have the third one here on the left-hand side. So I think we are released here. So we can now slowly come back with a nose cone,
and then
leave the guide wire in the LV,
slowly.
And coming around the aortic arch to the descending aorta, where we're going to close the capsule. And you can just show what you're doing now, Ole.
Yeah, this is also a new feature on the FlexNav system, so it's really easy. We push these blue knobs on the sides, and then in one fluent movement we can recapture that nose cone, and we make sure not to oversheet. And then we take it out. And
also very important is the nose cone coming down to the sheet and not the sheet up to the nose cone. So it's a more atraumatic movement. I'll just compress.
Yep.
And we're going to reinsert the 14 French sheet, and then we can do our assessments and see if anything further is needed. So we reconnect to pressure line. And we put pigtail into the LV.
Yep.
Get the pressure line here.
Yeah, wait a second.
So we see pressure is a little bit lower now than it was before. There's a good separation. We can try to make. We had 74 and 60
very nice
before.
separation now actually.
So it's 8 and 34. But again, take into account that the pressure is a bit lower than it was start of the procedure. So let's do an angiogram here, and we can go back to that cusp overlap view, which was. Do we have its LAO 0, caudal 31?
Caudal 31, yeah.
And you see also we have, we have pretty good commissural alignment. If you look at the outflow part of the stent frame, you see you have one of the tabs position on the right-hand side of the screen, and the 2 other one is almost overlapping on the non-coronary. It's not perfect, but it's close to be.
We've definitely avoided that one of the commissural posts is in front of the coronary.
Exactly, have severe commissural misalignment. So let's do an injection here.
Yeah.
And I think we have a very nice position.
Yes,
we
perfect.
are where we want to be, about those 3 millimeter below the aortic annulus. I don't see any paravalvular leak at all. And we have now done, I don't know, around 25 cases with this Navitor valve, and we haven't seen any patient having more than a mild PVL, and that's also aligned with what we saw at the first 120 cases presented at Euro PCR 2021.
Perfect.
So I think we complete this case. I mean, you saw that with this Navitor valve was very smooth implantation, no need for pacemaker, no for pacing during the deployment. Hemodynamic was stable, no conduction abnormality, no paravalvular leak, and also, even though we had that quite acute angulation in the aortic arch, since the system can make that small kink, it will take those challenging anatomies. So I think we can conclude this.
I think especially also in this particular case with a low flow, low gradient, this patient really has an ejection fraction around, depending on echo to echo, from 25 to 35. You don't need any pacing, very hemodynamically stable during the entire valve deployment. That's also a big advantage.
Okay, thank you.
Thank you.
So that was a superb demonstration, a flawless deployment of this Navitor with immediate excellent outcomes. So Lars, could you tell us more about the clinical outcomes coming from the larger registry to see what we can expect from a clinical patient perspective with Navitor next-gen device?
So thank you for the invitation to talk about the 30 days outcome for the new Navitor transcatheter heart valve. These are my potential conflict of interest. So the purpose of the PORTICO-ND study, which is a prospective, multi-center, global, international evaluation of the safety and the efficacy of the Navitor transcatheter heart valve in patients with symptomatic severe aortic stenosis who are at high or extreme surgical risk. It's going to use the new Navitor valve. It's a self-expanding, designed with intraanal leaflet position. It's based on the Portico valve, but there's been some important new features. First of all, it's been adding an active outer fabric cuff to mitigate the degree of paravalvular leak. And also the stent has been, radial force of the stent frame has been optimized across all valve sizes. It comes in 4 sizes, 23, 25, 27, and 29 millimeter, which covering aortic annuli between 19 and 27. The study is also continuing on examining the Titan valve, which is going to cover annulus up to 30 millimeter. So again, the study design, the patient was enrolled in 19 sites across Europe, Australia, and the US. Primary endpoint was all-cause mortality at 30 days, and also the rate of more than mild paravalvular leak at 30 days. There was a number of descriptive secondary endpoint as well. The first 120 patients is reported here. You see it's quite elderly patient, mean age 83 years. And also that the ST score at mean is 4%, and most of the patient had at least one frailty factor on top of this. Procedural outcome was excellent. There was no procedural mortality, no patient needed to convert it to surgery, and no patients left the cath lab without a new transcatheter heart valve. In 3 cases, 2.5%, there was a migration of the first valve, which was implanted, and a second Navitor valve need to be implanted during the same procedure. 30 days outcome, as I said, the primary endpoint was all-cause mortality at 30 days, and that was 0%, despite its elderly patient at high or extreme risk. There was 1 patient who had a disabling stroke. 2.5% of the patient have life-threatening bleeding. 1.7% of the patient acute kidney injury. And in 15% of the patient, there was a need for a new permanent pacemaker. It's important to understand that out of these 16 subjects who had a new permanent pacemaker, 30% already had pre-existing conduction abnormality prior to the TAVI procedure. Hemodynamics. As you would expect for a self-expanding technology, you find very favorable hemodynamics. Large opening area, 2.2 0 square centimeter, and very low transvalvular gradient, mean gradient 1 digit, 8 millimeter mercury at discharge, and 7 millimeter mercury at 30 days. And for paravalvular leak, this is probably the best results we have seen on any valve on the market today. 80% of the patient had none or only trace paravalvular leak, and of the remaining 20% of the patient, they all had mild paravalvular leak. So none of the patient had moderate or severe paravalvular leak. And that's also translated into the function class. You see at 30 days follow-up, 97% of the patient was in function class 1 and 2, and 85% of all the patients improved at least one function class from baseline. And 6 minutes walking distance also improved. It was 21 millimeter in a paired analysis, so a significantly improvement. So just to conclude, the low rate of VAC2 defined clinical event demonstrate that the Navitor valve offers a safe option for patients at high or extreme surgical risk who are suffering from severe symptomatic aortic stenosis, and the large opening area and low transvalvular gradient indicate a very favorable hemodynamics. And as I said, the absence of any moderate or greater paravalvular leak and the low rate of mild paravalvular leak, 20%, suggests that an active sealing cuff is an effective way to mitigate paravalvular leak. Thank you.
So thank you very much, Anthony and Lars, for these excellent presentations. So we know more now about the technology and the what we can expect in terms of procedural and clinical outcomes. But let's discuss furthermore about all these various aspects surrounding the technology. So I would like to start with you first, Anthony. You have demonstrated what are the new features of the Navitor device, particularly that Naviseal technology that prevents, and we could see it with Lars's case, paravalvular regurgitation. From a technical and a procedural perception, do you have the feeling that adding that external sealing technology generates some kind of instability, more slippery aspect to the device during the deployment? Have you experienced that?
Thank you for the question. The Naviseal sealing cuff, in combination with the integrated sheath system and the FlexNav system, really lend itself to a very stable device positioning. In addition to that, because the radial force, the expansile hoop force of the devices, in particular the 23 and 25 devices, have been increased and open in a more graded, predictable way with greater radial strength, my feeling overall has been that the stability has actually improved, not reduced. I'm finding that the devices do behave exactly as Dr. Sondergaard demonstrated in that beautiful case he presented, that once you find your height and you use the product information-based deployment technique, that the device opens up smoothly, calmly, predictably. Hemodynamics do not get knocked around, and you can achieve an implant depth without too much stress about needing to make lots of adjustments. So I don't think there's any real cost to the Naviseal. I don't think it adds any instability or anything like that.
So it's I understand now. We can understand that it's a very stable system, and we saw that during Lars's case. And you said that the radial force distribution is different. It's more homogeneous. So in terms of oversizing a ratio, do you think that we're going to use the same metrics as for the Portico iteration, or do you anticipate in the future that it could be more liberal and we could treat slightly larger anomaly with less oversizing thanks to that sealing technology? Because one of the reasons for such an oversizing is to prevent regurgitation. And thanks to the Naviseal, do you think that we could extend a little bit the sizing metrics in the future?
I think the nature of the system, that it's low profile and it's a relatively delicate system,
insofar as it doesn't have the same large spring forces that we see with some of the other self-expanding systems. And I think that's important. It's also why the system is more flexible to deliver, and you can get around knuckled aortic arches like we saw in Lars' case. I don't know that it will make a big difference to the oversizing that we do. I think with Navitor, because it is well engineered, because it is delicate, because it conforms to the annulus without outrageous radial pressures, that we will probably keep sizing it the same way. And I think the practice most of us use is, if there's a borderline size, we go one size up with Navitor with a high degree of comfort. The radial force in the system is nowhere near enough to cause annular rupture or issues like that on its own. That can only occur if there is aggressive post-dilatation performed with a balloon. In the cases of patients where it might be relevant, that would be patients who have annular perimeters of 84, 85, where the current system, the 29 system, really starts to get to the edges of what it can do without paravalvular leak at a perimeter of 85. I suspect that the Naviseal will help with those, but more importantly, not far down the pipeline, and we've implanted one of these in Australia already, is the Titan, which is a 35 millimeter portico, which still has a 15 French delivery system, the same delivery system as we use for the 29. It still is flexible, but has a 35 millimeter expansile diameter and the sealing cuff. So I think with those borderline larger annuli in the future, that's what we'll be using.
So thank you very much, Anthony. Maybe Michael, do we have anything from the chat so far?
I don't see anything from the chat, but if I could, Anthony, you mentioned about the benefits of intra-annular valves for ease of coronary access. We just have a bicuspid aortic valve session before this session, and we discussed that probably a supraannular position might actually give a bigger effective orifice area, so that it would more actually suit the bicuspid anatomy. So do you think this Navitor system actually is also good for the bicuspid anatomy?
Thank you for the question, and I'll give a brief statement, but then I'll ask Dr. Sondergaard, because it was about 5 or 6 years ago that Dr. Sondergaard showed me the slides of the intraannular versus supraannular design, and Dr. Sondergaard was prescient, because he I remember it was a talk in Brisbane before COVID, when we could still do those sort of things, and he was already discussing the concept of the lifetime journey of a patient and maximizing coronary reaccess and thinking about those sort of issues. I do not think that a supraannular system has any real advantages in bicuspid aortic valve disease. In fact, one might argue that potentially a supraannular system with leaflets really high up a flared tube, when you're dealing with those bicuspid leaflets, it can sometimes be difficult to open. It may be a disadvantage, but I certainly don't think there's any advantages of a supraannular system. And then you're also dealing with younger patients. So I think there's actually a disadvantage to using a supraannular system in younger patients, because coronary access is really important. But Dr. Sondergaard, could I ask you for comment about that?
So Lars, just to bounce on it. So we understand that it's useful it can be utilized in bicuspid. I would be a little bit more specific for you. We see that you demonstrated that we can achieve large EOAs and close to 2 centimeters squares, low single-digit mean gradient. In your experience, and it comes to bicuspid also, do you or post-dilate more frequently with the Navitor system, or is it something that a step that we can skip?
The radial force for this valve is the same as this for Evolut. So there's nothing changed, or nothing difference between the two platforms. What is the difference is that the opening force, the force the valve is actually coming out of this 6 millimeter delivery system, is less. And that's also why, as Anthony was saying, you have a more flexible system. It will take tortuous anatomy. It's a very good valve if you have horizontal aorta. But the cost of having a lower opening force is that you need to do more pre-dilatation. I would guess I probably do about pre-dilatation in about half of the patients here. So if the patient have moderate to severe calcification, I would do a pre-dilatation with this valve. So my threshold for pre-dilatation is lower with this valve as it is, for example, for the Evolut platform, which got a high opening force, but the same radial force. Bicuspid aortic valve, yes, you can use this valve. It's going to provide excellent hemodynamic outcome in bicuspid aortic valve. What we don't know is how is it going to be in the long term. One thing is to treat elderly patients with limited life expectancy with bicuspid aortic valve. But if you're going to move to younger patients with longer life expectancy, is an intraannular leaflet position going to mean that you have an elliptic configuration of the stent frame where the leaflets are based, and that's going to affect the durability? But again, to be honest, we can have our thoughts, but we have no data on that.
So thank you very much. I have another question for you, Lars. When you think about the lifetime management of a patient, particularly low-risk young patient, with this large open cell design, combined to what you nicely demonstrated, the commissural alignment to be more predictable, do you think that in the future, if the patient comes back and requires another TAVI procedure, we could use the same platform as a TAVI and TAV procedure and utilize the same thing with another commissural alignment? Do you anticipate that, keeping in mind the coronary access issue? Is it feasible, to your opinion?
It is feasible. As Anthony was showing in one of the slides, when you implant a second valve, you're going to push the leaflet aside from the first valve, and these leaflets are going to be jailed between the two stent frame. And if you've got a supine leaflet position, you're going to have a tunnel of tissue from the LVUT to the ST junction, which will mean that you may have flow to the coronary arteries, but it's probably going to be impossible to access them. So if you have an internal leaflet position, even though those are pushed aside, you will still be able, on the top of that leaflet skirt, to access the coronary arteries. So I think it's very important to think about that if you're going to treat patients who likely will come back for a valve-in-valve procedure, that after the second valve, you should still be able to access the coronary arteries. And I think this Navitor platform certainly gives you the option for that.
We see a lot more calcified annulus, calcified valves in Asia. Do you think this active Naviseal technology actually would help us more to decrease the incidence of paravalvular leakage?
Yeah, but what we have seen here for those first 120 patients that you saw, even though it was very old and quite a few of the patients had very calcified aortic annulus, there was none of the patients who have more than a mild paravalvular leak. And actually 80% of the patients have none and only trace. So I think as I know it, it's probably the best of the class for the time being for these initial reports on the 120 patients.
So thank you very much, guys. This was a very comprehensive overview of the features of the Navitor system, what we can expect in terms of clinical outcomes, and what we can foresee for the future, particularly for our low-risk patients. So I'd like to wrap up just by saying that this seems to be a technology that perfectly suits the expectations for younger and lower risk patients with longer life expectancy. For these patients, the concerns are first stroke, and the stroke rate was really low. The Zeppelin stroke rate was really low for the first 120 patients treated with that technology. Paravalvular regurgitation, it seems to have become virtual with the Naviseal technology. Vascular complications, a very flexible system that prevents vascular complications and enables tracking through very challenging anatomy. So this is something that is extremely important. Maintenance of the access to the coronary arteries, and with the large open cell design and the nice demonstration that Lars' team has provided us with of commissural alignment, we can keep the access to the coronary arteries with this type of design. And it seems that there is no cost to pay in terms of pacemaker rate. So this is definitely a device that seems to be adapted for our younger and low risk patients. So I would like to thank you guys for giving us such a very nice overview of the technology and the clinical outcomes, and sharing with Michael and myself this nice and interactive discussion. I would like to thank Abbott for sharing, for allowing us to have this type of session, and I wish you all the best for the rest of the meeting. Thank you, guys. Bye-bye.
Thank you. Bye-bye.